Hi. Today I'd like to talk about prediabetes, a common and serious condition. It greatly increases an individual's risk of developing diabetes, and there are several other comorbidities associated with prediabetes. Luckily, repeated studies have shown that prediabetes can be treated effectively by health behavior interventions, particularly interventions targeting healthy diet and weight, and a healthy amount of physical activity. Prediabetes is defined as higher than normal blood glucose levels that aren't yet high enough to be classified as diabetes. Prediabetes is a major risk factor for developing diabetes, but also many problems with organs such as kidneys, eyes, nerves, and the heart are associated with prediabetes as well as diabetes. It's clearly important to address prediabetes. According to the CDC, approximately 1/3 of Americans have prediabetes. Since prediabetes is so closely linked to diabetes, we should also look at diabetes prevalence to gauge the magnitude of the public health issue. In 2015, 9.4% of Americans had diabetes. The annual healthcare costs of treating diabetes in the U.S. are $105 billion. Diabetes is a global health issue as well, with 8.8% of the world population, or 415 million individuals, having diabetes in 2015. This number is predicted to rise to about 642 million, or 10.4% of the expected world population in 2040. Currently, the global healthcare cost of diabetes is estimated at $825 billion. This map shows diabetes prevalence in the U.S. You can see that diabetes is associated with location, with the highest prevalence in the southeastern region of the country. Race and ethnicity are risk factors for diabetes, with the highest prevalence among American Indians and Alaska Natives, non-Hispanic blacks, and Hispanics. Diabetes prevalence also varies inversely with education level. There are several unmodifiable risk factors for prediabetes, but we'll focus our attention on the modifiable risk factors: low physical activity and being overweight. Behavioral interventions have been shown to be effective at treating prediabetes, and by this I mean preventing diabetes, and blood glucose levels can still be returned to normal at the prediabetes phase. Some studies have shown behavior change to be more effective than medication, and this result was observed across different ethnic groups. Reviews of behavioral interventions have found that behavior modification could reduce the relative risk of developing diabetes when compared to a control group by 40 to 70%. One difficulty in prediabetes treatment is that behavioral changes directed at these two risk factors are difficult to maintain long-term. In addition, individuals with prediabetes often do not yet see symptoms, so it may be difficult to communicate the severity of the issue and the importance of taking action. Another important barrier to treatment is that many individuals with prediabetes have not had the condition diagnosed. Estimates are that 90% of individuals with prediabetes are unaware of their condition. The first theory I'd like to talk about is the theory of planned behavior. The basic premise is that the intention to perform a behavior is the best predictor of behavior performance. The constructs include 3 determinants of behavioral intention: a person's attitude or beliefs about the outcomes of performing the behavior, a person's subjective norm, or his or her beliefs about whether significant others approve or do not approve of the behavior, and a person's perceived control of their ability to perform the behavior. The first example of an intervention targets weight loss in adolescents who are overweight or obese. The intervention consisted of 5 training sessions designed according to theory of planned behavior constructs that addressed important issues related to weight loss. Attitude, subjective norm, and perceived behavioral control were all included in the design of the training sessions. Positive attitudes about weight loss behaviors were fostered by discussing the importance of diet and exercise in weight loss, as well as increasing knowledge of obesity risks. Subjective norm was addressed by including parents in training sessions and emphasizing the importance of one's circle of contacts in weight loss. Perceived behavioral control was increased through direct and vicarious experiences of weight loss success, verbal persuasion, and encouragement. Encouragement of participants continued for the 6 weeks after the training sessions ended through weekly phone calls and an educational booklet provided to participants. The second behavioral theory I'd like to look at today is the empowerment model. The overall goal of empowerment models is to decrease feelings of powerlessness and give individuals a feeling of control over their lives called empowerment. Self-efficacy is considered an outcome of an empowerment model instead of a construct. According to this model, when people understand they can make decisions about their health, they're more likely to take responsibility for engaging in healthy lifestyle behaviors. The ABC Empowerment Program has 3 phases: awareness raising, behavior building or action, and checking results or reflection. The awareness phase involves both increasing people's awareness of the health condition, as well as awareness that they have both the right and the ability to make their own decisions about their health. In the action or behavior building phase, the healthcare professionals facilitate healthy behavior through answering questions, helping people set goals, and integrate their new knowledge into their daily life, and make their own decisions about their health care. In the final phase, checking results or reflection, individuals are supported in assessing whether they met their goals and adjusting their actions or goals as needed. The second intervention we'll look at is a prediabetes intervention using the ABC Empowerment Program. Participants in this study were individuals over 20 who had prediabetes. Researchers set up a randomized controlled trial comparing the intervention to routine clinical care. The intervention sessions were aligned with empowerment constructs. During the awareness phase, the focus was on building a partnership between participants and healthcare providers, as well as increasing patients' self-awareness and recognition that they can make decisions about their health. In the behavior building phase, participants were guided in developing their own plans to implement a healthier lifestyle. Throughout the intervention, participants kept journals about daily activities related to intervention topics and discussed them with other participants at the next meeting. There were also opportunities to share experiences with maintaining motivation and overcoming obstacles, increasing social support and empowerment. In the checking results phase, participants were guided in determining whether their goals had been met. So now to critique the theories. First, we'll look at predicting change in dietary and physical activity habits. Researchers examined the internal consistency of the theory of planned behavior constructs and found they were strongly associated with behavioral intention regarding healthier eating and improved physical activity. In addition, the constructs together with behavioral intention were strongly associated with improvements in these behaviors. The strongest associations were between perceived behavioral control and intention. This research points to the theory of planned behavior as an effective theory for promoting healthy behavior initiation in eating and exercise. However, the evidence is not as clear for long-term maintenance. For example, relatively little of weight loss that occurs during an intervention is maintained in the long term for periods of more than a year. This points out the importance of shifting responsibility for regulating healthy behaviors from the intervention leaders to the individual. Research has shown that predictors of maintenance of healthy outcomes include goal setting and self-monitoring of behavior, and these predicted both short and long-term effects on healthy diet and physical activity improvements. Social support and methods centered on the individual making choices, such as motivational interviewing, have also been shown to increase empowerment and are associated with maintenance of change over periods of longer than 12 months. Now let's evaluate the 2 example interventions we looked at against these sets of criteria. The theory of planned behavior intervention for weight loss targeted each of the 3 constructs of the theory of planned behavior and successfully positively affected behavioral intention, behavior, and health outcomes. Goal setting was promoted by watching videos or slideshows about patients who were overweight and who overcame their difficulty, and encouraging patients or participants to set goals of their own. Social support was also targeted by including parents in intervention sessions and emphasizing the role of social network in healthy behavior change. A stronger emphasis on empowerment and the individual's rights and responsibilities to make decisions and take action on their health would increase likelihood of long-term effectiveness in this intervention. Adding a motivational interview component to create goals, as well as a reflection component to think about whether goals were met and whether they need to be modified, what challenges came up and how they were or could be addressed, could make the intervention more effective in the long term. The Empowerment Program intervention focused on predictors of behavior maintenance, including self-management, goal setting, and empowerment. And after 3 months, the treatment group still showed larger improvements in healthy behavior, self-efficacy, and reduced BMI than the control group. This intervention created a network of social support among the participants by including opportunities to discuss journal entries and experiences relating to intervention topics. One potential shortcoming as far as long-term maintenance of behavior is that the social network is specific to the intervention. After the end of the intervention, individuals may lose the feeling of social support, which in turn could limit long-term maintenance of health behaviors. So, the next steps in designing a new pre-diabetes intervention. The goals of this new pre-diabetes intervention are to increase physical activity and reduce added sugar intake. These two behaviors are expected to lead to a healthier weight and improvement of blood glucose levels. The constructs of the intervention need to be positively associated with behavior change and with self-management. In addition to making people aware that they can make decisions about their health, the intervention should emphasize that people have a responsibility to make decisions about and take action around their health. A construct of awareness will be included to specifically address these components. So, here's the model for this intervention. The 3 constructs of this model are perceived behavioral control, perceived benefits and barriers, and awareness. All 3 are intended to increase intention to perform the target behaviors of increased physical activity and decreased added sugar consumption. The intervention will contain an interactive education component aimed at increasing awareness of the risks of diabetes and the benefits of adopting healthy behaviors. Sessions will also include information on healthy diet and types of physical activity, again with a focus on engaging participants in developing their own ideas of how to integrate behaviors into their own life. Motivational interviewing techniques will be used to determine what behaviors participants feel they can control and what things are barriers to change. The awareness component will focus on the intention to change through education about prediabetes risks and the best ways to address them. Awareness of the individual's ability to make decisions about their health will be affected by hearing from other individuals about their own decisions about health and promoting awareness that decisions about health are not only their right but also their responsibility. Sessions on these topics could include group activities such as role-playing, as well as keeping journals and discussing examples from their lives where participants made a decision to take responsibility for their health. For example, exercising even though they were tired, or success with a plan for healthy eating while attending a party. In conclusion, the constructs of the theory of planned behavior have been shown to be strongly associated with healthy changes in diet and physical exercise. In order to treat prediabetes, though, and prevent progression to diabetes, long-term weight maintenance is key. To support long-term healthy behavior maintenance, the motivation to perform the healthy behaviors, as well as the responsibility for regulating the behaviors, needs to be internal rather than external. Although there is some evidence that the constructs of the theory of planned behavior can also predict behavior maintenance, the internal motivation component is important enough that there should be a separate construct dedicated to it. Thank you.